Welcome to the Doctoring 1 Musculoskeletal or MSK Cluster Exam. The MSK exam is different from the other cluster exams you learned so far because the full MSK exam is not usually performed in its entirety. This is because most patients will have concerns regarding a specific limb or joint. Therefore, it's better conceptualized as a whole compilation of exams that are available when needed. Typically, an exam is limited to the joint just proximal and distal to the joint in question. For example, in a patient presenting with knee pain, it would be reasonable to limit the exam to the hip, knee, and ankle. In the MSK exam, we will inspect, palpate, and strength test. We'll also add a new exam called the range of motion. Range of motion refers to the normal arc of movement a joint is normally capable of. When we ask the patient to perform a range of motion of a joint, it is called active range of motion. For selected joints, we'll also demonstrate what is known as passive range of motion when the examiner moves the joint for the patient. Start the neck or cervical exam by inspecting for the cervical concavity and looking for any erythema or deformities. Next, palpate the spinous processes in the midline and the paraspinous muscles just lateral to the midline. In most patients, the spinous process at C7 is typically the most prominent spinal process. For active range of motion, ask the patient to bring his chin to his chest. This is flexion. Then ask the patient to look up at the ceiling. This is extension. Have the patient look over to the left and then the right shoulder. This is rotation. Finally, ask the patient to bring his ear to his shoulder. This is lateral bending. During this maneuver, obviously make sure that the patient is not shrugging his shoulders, since this is not lateral bending. Start inspection by standing beside the patient and observe the thoracic convexity and the lumbar concavity. Standing behind the patient, observe for any asymmetry or deformity. Palpate the thoracic and lumbar spinous processes at the midline, noting any tenderness. Next, palpate the paraspinous muscles for any tenderness or tightness and compare that with the other side. Finally, palpate the iliac crest. This is a useful landmark because horizontally it corresponds to the level of the spinous process at L4. For active range of motion, ask the patient to bend forward and try to touch his toes. This is flexion. Ask the patient to bend back as far as possible. This is extension. Next, standing from behind the patient, ask the patient to rotate or twist his shoulders while you are stabilizing his hips. This is rotation. While in the same position, ask the patient to bend to the side. This is lateral bending. Start the shoulder examination by inspecting the patient for shoulder symmetry and note any deformities of the clavicles, shoulders, or proximal arm. During palpation, start at the sternal notch and move laterally over the sternoclavicular joint and laterally over the clavicle until you reach the bony prominence of the acromioclavicular joint. Just lateral to the acromioclavicular joint is the acromion itself. Lateral to the acromion is the greater tubercle of the humerus, where the rotator cuff muscles insert. If the acromion is followed posteriorly, it becomes the spine of the scapula, which you can follow medially. Superior to the spine of the scapula, you'll palpate the supraspinatus muscle, and inferior to the spine of the scapula, you'll palpate the infraspinatus muscle. Finally, finish palpation by palpating the proximal humerus. For active range of motion, ask the patient to raise the arm in front of him and overhead. This is flexion. Ask the patient to raise the arm behind him. This is extension. Ask the patient to raise the arm to the side and overhead. This is abduction. Ask the patient to cross the arm in front of him, like reaching for a seatbelt. This is adduction. Ask the patient to keep the elbow to the side and bend the forearm to 90 degrees. In this position, ask the patient to move the hand towards the body, which is internal rotation, and away from the body, which is external rotation. For the shoulder exam, it's common to perform a passive range of motion. Ask the patient to relax the arm and shoulder and move the patient's arm in the same motions as you did for active range of motion. Finally, for strength testing, have the patient actively push against you as he goes through the active range of motion. Note any weakness. Start the elbow exam by inspecting the arm, elbow, and forearm for deformities, swelling, or skin changes. Next, palpate over the same areas for deformities or tenderness. Key areas to palpate include the lateral epicondyle, the medial epicondyle, and the olecranon of the ulna, which lies between the two epicondyles. For active range of motion, ask the patient to bend the elbow. This is flexion. Straighten the elbow. This is extension. Turn the palm down. This is pronation. And turn the palm up like he was holding a bowl of soup. This is supination. For passive range of motion, ask the patient to relax the arm and move the patient's forearm in the same motions as you did for active range of motion. Finally, for strength testing, have the patient actively push against you as you go through the active range of motion. Start the wrist and hand exam by first inspecting for swelling or deformities. Next, palpate the distal forearm, the carpal bones, the metacarpals, and the phalanges for tenderness or deformities. Grip strength is a good overall test of the finger flexors and performed by asking the patient to grasp and squeeze the second and third fingers. To test thumb active range of motion, ask the patient to move the thumb towards the base of the pinky. This is flexion. Away from the other fingers is extension. Pressing the thumb against the index finger is adduction. Lifting the thumb anteriorly away from the palm is abduction. And finally, touching the tip of the pinky is opposition. For thumb strength testing, have the patient actively resist as he goes through the active range of motion. For the other fingers, we will test flexion. With the hand flat and against the table, stabilize the DIP and PIP joints with your fingers to isolate and test each individual joint. To test abduction, ask the patient to spread the fingers and test strength by squeezing the fingers together. To test for adduction, ask the patient to bring the fingers together and test strength by placing your fingers in between the fingers. Test active range of motion of the wrist by asking the patient to bend the wrist down and up to test flexion and extension. With the palm up, moving the fingers towards the midline is adduction or ulnar deviation, and moving the fingers away from the midline is abduction or radial deviation. This is followed by strength testing of the same movements. Note the anatomic snuff box, formed by the abductor and extensor muscles of the thumb when it is extended and abducted. Start the hip exam by observing the gait and noting any avoidance of weight bearing to a particular side. Palpate the greater trochanter of the femur. It is essentially the only bony prominence below the iliac crest. Testing active range of motion with the patient standing, have him hold on to the wall beside him and ask him to bring the knee up to the chest. This is flexion. Ask him to raise the knee behind him. This is extension. In a lying position, ask the patient to raise the knee to the chest in the supine position, and then have the patient turn over to the prone position and ask him to raise the knee into the air. This is extension. Here I demonstrate the passive range of motion for flexion extension when it is performed in a lying position. With the patient facing and holding onto the wall, stabilize the pelvis in order to isolate the movement of the hip, and ask the patient to move the lower leg out to the side. This is abduction. Next, ask the patient to bend the knee and cross the lower leg in front of the other leg. This is adduction. With the patient lying supine, flex the knee and churn the lower leg across the midline. This is external rotation. In the same position, turn the lower leg away from the midline. This is internal rotation. Have the patient sit on the exam table with the knee flexed to 90 degrees. Inspect the knee for any swelling, erythema, or deformities. First, palpate the bony patella and identify its lower margin. This horizontal level corresponds roughly to the joint line, so palpate medially and laterally to identify the joint line. Next, observe and palpate the concave space on each side of the patella. If there was an effusion in the suprapatellar bursa, these spaces would be obliterated. Next, palpate the quadricep muscles above the patella. Finally, palpate the popliteal fossa behind the knee and examine for any masses or tenderness. To test active range of motion of the knee, have the patient straighten the leg for extension and bend the leg for flexion. Here I demonstrate passive range of motion for the knee. Inspect the ankle and foot for swelling, bruising, or deformities. On the lateral aspect of the ankle, inspect and palpate the lateral malleolus, formed by the distal fibula. Palpate the anterior talofibular ligament, calcaneofibular ligament, and the posterior tibiofibular ligament. These ligaments are the ones that are most commonly involved in ankle sprains. On the medial aspect of the ankle, inspect and palpate the medial malleolus formed by the distal tibia. Palpate the deltoid ligament that stabilizes the medial ankle. Next, palpate the calcaneus, the metatarsals, and the phalanges for tenderness or deformity. Be sure to actually observe the plantar surface of the foot and palpate the calcaneus and the metatarsals. On the posterior aspect of the ankle, palpate the substantial Achilles tendon that attaches to the calcaneus. For active range of motion, ask the patient to point the foot towards the floor. This is plantar flexion. Ask the patient to point the foot towards the ceiling. This is dorsiflexion. Ask the patient to bend the heel inward. This is inversion. And ask the patient to bend the heel outward. This is eversion. For a passive range of motion, have the patient relax the ankle and move the patient's ankle in the same motions as in active range of motion. Finally, for strength testing, have the patient actively push against you as he goes through active range of motion. Finish the exam by asking the patient to wiggle his toes.